Hello again. Thank you so much for sticking around. I know it's getting late. It'll be short, sweet, and hopefully less controversial, but something that will make you think about how we do dose and prescribe NSAIDs for our patients in the emergency department. Totality is the dark side of the NSAIDs. Same thing, little book. And I'm not going to ask you, it's a very silly question. Raise your hand if you've yet to use NSAIDs for managing pain in the emergency department. And you'll agree, this is by far the most commonly used class of analgesics, antipyretics, and anti-inflammatory agents that they use in the United States and probably worldwide as well. And they're rightly so, because they work, they're effective. But there's something else about them that sometimes we tend to forget. And I'm going to start with a few slides to refresh your memory. We all remember the way the NSAIDs work. They're non-competitive inhibit COX-1, COX-2 enzymes. And based on this, they can be non-selective, such as ibuprofen. They can be selective, such as ketorolac, COX-1, and they can be COX-2 selective. So why do we need to know at all their selectivity? Well, it just so happens that based on selectivity, you can assume, you can predict or expect even what particular set of toxicity NSAID will lead to it. If you have an NSAID which is more COX-1 selective, you may expect for them to have more gastrointestinal toxicity. If you have an NSAID, which is a COX-2 inhibitory activity, you may expect, in theory, the practicality, to be probably more toxic for the heart and vessels, and rightly so. Now, this is a concept that tends to be omitted and forgotten too often by the physicians. How many of you have known that NSAIDs as a class can be divided in 6 subclasses? Raise your hand. As expected, thank you, sir. The reason is important. I'll tell you this practical lesson. How many of you ever had a patient who comes in and says, look, I threw my back at work, it's been 3 days already, I'm taking Advil, Aleve, Naproxen, Motrin, it doesn't work. And you go, okay, I'll help you. So nurse comes in 5 minutes later, this is your ibuprofen. So you look like a jerk, patient gets upset and says, Doc, didn't you hear what I said? It's been 3 days, I'm taking this thing, you give it to me, it doesn't work. Now, if you do know this, that's your time to shine. Because I'm using this table to show that you can utilize the concept what's called NSAID rotation. If one of the subclasses doesn't work, which in this situation, naproxen and ibuprofen, they live together in one class. Instead of being a jerk and giving patients the same medication, why don't you give them something different? And my approach is switch them to diclofenac. They work differently. It's the same class, but they work differently, and you may see the difference. You can talk afterwards, it's been 3 days, maybe you should do something differently, blah, blah, blah. But the point being, NSAIDs rotation is important when it comes to ED management. Now, it just so happened that over the past 10 years, there's a great deal of literature that clearly states that there is a well-known dose-related risks of commonly used NSAIDs in our country, in our EDs, such as ibuprofen, naproxen, ketorolac, and such, that lead to certain severe side effects that will introduce patients to severe morbidity and mortality. And we all know, in the current therapeutic landscape of pain management, when everybody's going this opioid crisis, NSAIDs become almost gold guy. They're effective, but the risk is real, and the dose and duration of therapy is even more real than ever before. This is why is it so important right now to put more thought before you start prescribing NSAIDs to patients. All right? And we're talking about the toxicity, we're talking about the gastrointestinal toxicity, renal insufficiency, we're talking about the cardiovascular with respect to knocking your coronaries and causing demise and worsening your CHF. Risks are real. And this particular risk is we're accustomed to think, you've been taking NSAIDs for 2, 3, 4 months, years, centuries, of course you're going to have these side effects. It's not entirely true. 2013 Matthew put a beautiful paper together with some relative risks of developing those toxicities, either GI, cardiac, renal, on patients who are taking high-dose NSAIDs for up to 2-3 weeks versus those who are taking low and medium dose. And see what they found out. Let's look at the gastrointestinal risks. Low, medium, they do okay. But if you go on the high dose, indomethacin, ibuprofen, naproxen, diclofenac, they double the risk of causing GI, mostly GI hemorrhage. Peroxicam or Veloxicam can go up to 3 times, and the medication that is not shown on the table, which is ketorolac, goes up 5 times. Relative risk of ketorolac cause GI bleed is 22 versus ibuprofen 1.8. Cardiac, COX-2 probably do better, but so not. Naproxen appears to be most cardioprotective. But ibuprofen, if you use in a high dose, risk of having cardiovascular toxicity go up by 75%. So is the clofenac. Risk is real. Similarly, Coxib knock off your kidneys, so is naproxen. So risk is there. High dose make things worse. Low, medium, probably not as much, but still do. More numbers. If you compare patients who are taking low dose versus those who are taking high or medium dose, those who are taking high dose have a 28% higher risk of having cardiovascular problems, 104% higher risk of developing gastrointestinal toxicity, and about 38% of having renal insufficiency or suffering from acute renal failure or acute and chronic. Furthermore, 80% of commonly prescribed NSAIDs in the United States across all the specialties are prescribed at the highest allowable dose according to the package insert, according to FDA approval. All right? 8% of patients who are giving a prescription for NSAIDs taking more than prescribed. 35% of patients to 30% of patients who are giving a prescription of NSAIDs, taking over-the-counter NSAIDs on top of it. And about 33% of patients believe the pain is so severe that you take more and more and more. More numbers. 94% of physicians believe that NSAIDs should be given for the short period of time with the lowest effective dose. But 19% of physicians across all specialties in the United States, once again, prescribe the maximum allowable dose according to the packet insert. Okay, I'll take it. 15% of physicians give a prescription for NSAIDs to patients who are taking over-the-counter NSAIDs without asking them if you are taking anything else. 40% of patients who are taking over-the-counter NSAIDs take double, triple dose of it because the pain is so severe. 92% of physicians believe that they need to speak to patients about the risks of NSAIDs. Half of them actually do it. So things are there, and all of a sudden, from this beautiful, beautiful thing that's very effective, NSAIDs becomes not so happy. And as one said, the difference between a drug and a poison is a dose and duration. And this is very, very important when it comes to NSAIDs. Now, back to real life, back to clinical stuff, no more numbers. AAA agents, right? Analgesics, antipyretics, and anti-inflammatory agents, which is good. As a class, though, NSAIDs have a unique properties, which not really often discussed in the major textbook, and that's called ceiling effect. And just to make things more complicated, it's not just they have one ceiling effect, they have two, technically three, but I'm not going to talk about the third one. Let's stick to two for now. They have analgesic ceiling effect, and they have an anti-inflammatory ceiling. What does it mean? Analgesic ceiling implies that there is a dosing threshold beyond which any further increase in NSAIDs dosing will not result in any additive analgesia. There is a limit to which NSAIDs will stop, a certain limit, and they will not work anymore as analgesics. However, should you be increasing the dose, you go over the threshold for analgesia, you hit the threshold for inflammatory properties, which is usually limited by the maximum allowable dose of NSAID in the packet insert. Analgesic ceiling effect is significantly lower or lesser than full anti-inflammatory ceiling. Examples. This example of ketorolac. Once you hit 10 milligram mark, if you go at 15, 30, 45, 60, you will not have any difference in analgesia. However, you might get a little difference in anti-inflammation. Ketorolac is a shitty inflammatory drug to begin with, but the point being it goes up higher and higher and higher. Ibuprofen. So at the bottom there's the data, and I'll talk about it later in a second, 400 versus 600. There is, as you can see, there's a minimum difference of ever between 400 and 600, which means there is a ceiling beyond which NSAIDs such as ibuprofen will not give you any more analgesia, but anti-inflammatory properties will go up higher, and that's what kills the patient. Higher the dose, more anti-inflammatory properties, more cardiac toxicity, GI toxicity, renal toxicity. The only difference between analgesic ceiling and full dose of NSAIDs is the duration of analgesia. If you give somebody 10 mg of ketorolac and 30 mg of ketorolac IV, the duration of analgesia will be shorter for those patients who have 10, somewhere between 45 to 55 minutes. While in reality it may not be as much, it exists only because NSAIDs do follow a pattern of linear kinetic. Higher the dose, longer the effect. Is it important in DT? Probably, but maybe not to the extent that if we believe the higher dose will be detrimental to patient's health. Here is the most important slide, and I want you to try to remember this. In a setting of acute injury, degree of inflammation does not warrant a full anti-inflammatory dose of NSAIDs. The analgesic ceiling dose will have enough anti-inflammatory property in within to take care of the acute pain. In a setting of acute injury, musculoskeletal, visceral, somatic, cutaneous, you name it, acute injury, that degree of inflammation, the tissue destruction that leads to inflammation, does not warrant a full anti-inflammatory dose of NSAIDs. This is an important concept. For that very reason, next time you have a patient who comes into UED and you consider giving him NSAIDs, remember analgesic ceiling dose. It's significantly less or lower than full anti-inflammatory dose, which is limited by the packet insert according to FDA. So it all sounds terrific and everything. Let's look at the evidence. Ibuprofen, analgesic ceiling, 400 milligram per dose, 1200 milligram per day. Given PO, IV, and that's pretty much it. 400, and the data comes in, most of the data comes from the dental surgery. There's just lots of patients who underwent molar tooth extraction, which is wisdom tooth, and they were randomized to receive 400 milligram of ibuprofen, 600 and 800. And at 6 hours mark, none of them had any difference in change in pain score. They all did well. Two sets of data, 400 versus 600 versus 800, or 400 versus 800. No difference, up to 6 hours. So it worked fine. Based on the dental literature, and the one comes from surgery, analgesic limit for ibuprofen is 400, not 6, not 8. And frankly, should be prescribed 3 times a day for 2-3 days. Naproxen, which is interesting medication, because in my formulary we always give 500, single dose. And when I send patient home, we have it's a BID dosing, life is beautiful. But if you go to any drugstores and if you look at over-the-counter label, it says to 20 or to 50. And they take one pill twice a day, which means analgesic ceiling dose lies somewhere between 250 to 450, not even 500. If you look at the Oxford analgesic table with respect to the number needed to treat to achieve 50% or greater change in pain score at 6 hours, the number needed to treat for 250 milligram of naproxen is exactly the same as 500. It's 3. So technically, in my personal practice, I don't give 500 milligram. It's 250 twice a day, and that's it. Ketorolac. You guys ready for it? 10. IV, IM, PO. Frankly, I usually push for 10 milligram per 24 hours, but that's a really stretch, and almost always somebody will grab the fork and stab me. We try to do so, but let's be fair. We can do 10 milligram Q6, which amounts about 40 milligram per 24 hours. Not 30 IV times 1, not 60 IM times 1, repeat every 6 hours. It doesn't work like this for pain. Analgesic ceiling dose for ketorolac is 10 milligram per dose. This is important to know. Diclofenac, highly underutilized medication in the United States, worldwide #1 agent when it comes to NSAIDs. Beautiful medication. Slightly more cardiotoxic, but actually works wonders. Analgesic ceiling, 50 milligram. Range, 100 to 150 per 24 hours. I would probably elevate to 50 BID. Number needed to treat for 50, 2.7, 400, 2.9. Essentially the same. And we're talking about, once again, number needed to treat to achieve 50% or greater change in pain score at 6 hours mark from the baseline. So it's a good number. This medication rarely used if ever, but I've seen patients coming in from overseas sometimes, and they're on this medication. I kind of thought, maybe it's good to get educated and impress them. They don't know what you're taking. So dexketoprofen and ketoprofen. As you can see, the lowest dose for ketoprofen is 25 milligram, not 100, and for dexketoprofen it's 12.5. Similar number needed to treat again. The last medication I'm going to bring up to your attention is meloxicam, piroxicam. My personal belief, they should not be used in the emergency department. They're toxic. They take forever to kick in. That's why you can actually dose them once per 24 hours. But the analgesic ceiling dose is 7.5 milligram per 24 hours, not 15, not 25. Some of you may have heard recently there was a company that was trying to push intravenous piroxicam here in the United States, 30 milligram IV, Q6 hours, it's a suicide. So 7.5 per 24 hours if you ought to use piroxicam, but I would not recommend to use it in BD. Now, you can tell me, you know what, it's all fun. It's all good, but why do I care? I give one freaking pill, one freaking shot to my patient and they're on their way. Why need to worry about this? Everybody's single dose. So the question is, can single super analgesic dose of NSAIDs make patients stop it? So let's take a look. In the emergency department, my favorite study by far, and I don't know how to pull this up. Imagine you in residency program, you're the faculty. Your residents come in, all 20 of them, presumably healthy, and you tell them, it's 8 o'clock in the morning, we're all going to get a blood drawn. So you draw the blood and you check the bleeding time. And then you give them ketorolac, 60 milligram IM, all of them, just shit and giggles over it. Then you keep them and you go for the lecture, 4 hours, and you say, you know what, we're going to do blood drawn again. And you do another one, and you compare the bleeding times. Before and after, single dose of 60 milligram of ketorolac given IM. Presumably healthy EM residents with an underlying coagulopathy or bleeding disorders. I don't know how they got through RB. This is super medical, but let's not talk about this. So here are the results. The bleeding time went up from 3 minutes before to 5.5 after. 2.5 minutes increase in bleeding time after single IM injection of ketorolac. What if those patients weren't healthy? What if that underlying coagulopathy didn't know about this? They would bleed. Very annoying this. Single dose, didn't make. 1995, 195 beautiful children went tonsillectomy and adenoectomy. They got perioperatively 30 milligram IV of ketorolac. And after that, they all went to PACU, and they were supposed to be chilling. Just so happened that 10% of those kids who received ketorolac ended up going to the OR for rebleed and re-exploration, versus 2% of kids who did not receive ketorolac. Single dose, 30 milligram IV, 10% of kids ended up bleeding again, had to go back to the OR. And my favorite case. 36-year-old gentleman undergoes vasectomy. I should stop right here. I have no idea why a 36-year-old would ever want to go vasectomy, but that's his business. He gets the surgery and he gets a prescription for ketorolac, 10 milligram every 6 hours. He takes 3 pills. So I have a little bit of discomfort in the chest. Gets up in the morning, takes the 4th pills, 40 milligrams. At noon, at lunch, he goes to the bathroom, starts coughing up blood. He's had a little bit of shortness of breath. 40 milligrams over 24 hours, which is taken like one analgesic saline. He comes to the emergency department, he has a chest CT, he has a diffuse alveolar hemorrhage. He gets admitted to ICU for 3 days, he did well. 10 milligrams every 6 hours. And he bled his lung after 40 milligrams. Healthy gentleman, vasectomy. So let me sum this up. NSAIDs are cool, they're super effective, and they really do wonders. And any shape and form, in pill, in a suppository, in IV form, and of course topicals, which we're going to not talk about today, unfortunately. But point being, they help in patients in pain, and I have no problem with it. But what I'm pledging to you all, next time when you go back to your respective shops and you have patients in pain, and you consider giving NSAIDs, please honor the concept of analgesic saline in the ED. And specifically when a patient goes home on discharge, because when you auto-discharge it, consider utilizing the very simple concept. Lowest effective dose for the shortest duration of therapy. And my personal approach is, I do more than 3 days of NSAID. I'm not trying to knock all the platelets in 5 days and such. If after 3 days, after oral NSAID therapy, based on their analgesic saline, patient is not feeling well, they either come back to me and we need to reassess their pain management, or if I believe they're benefiting from NSAID, we should be switching to topicals. This is me. I want to thank you so much for having me today, and we'll take questions if you have any.